Welcome back to the COVID debate with the New Indian Express. 6 months into what we've now seen is an unprecedented pandemic, COVID has still left the man on the street with a lot of questions. Can I get COVID if I've had it once already? Is there a vaccine around the corner? Which country is going to get there first? Are these drugs for real? How is it a 70-year-old manages to beat the virus and a 20-year-old succumbs to it? Is the virus really mutating at a speed that no one has understood yet? To understand the science behind the virus and to get these questions answered, TNI editor G.S. Vasu speaks to D. Nageshwara Reddy, a world-renowned gastroenterologist and the chairman of AIG hospitals, and a man who's been studying the science behind the spread of the virus very, very carefully. These are the answers that he had for us.
People are dying are mostly those who are having obesity. If you look at the number of infections in our country, in fact, even 77,000 is underestimation. My view is it will be at least 5 times more actually. So in fact, I don't think underreporting is there in our country because you can get statistics from March and all. But definitely as we go forward, September or October, the transmission will come down because of antibodies. Initially, people are talking about hand washing, very important, very important. Now we know that hand washing is important, but less important than masks. Mask and follow physical distancing. It is equivalent to 90% effect of lockdown. That's why airports are more dangerous than airplanes. Because of this mutation, the vaccine effectiveness will be still there.
Dr. Reddy, thank you for being back with the New Indian Express. I think we last spoke about 4 months ago when the virus was still in its early stages in India. And now, today, going by the data that has been put out, we have achieved a rather dubious record of highest ever spike in a single day in any country in the world. So, how do you, compare the situation between, say, 4 months ago and now? From whatever understanding you have gained by way of treating patients and going through research, etc.
Yeah. So I think first of all, thank you very much for this opportunity. First, to clarify that this looks like a very big spike. In fact, if you look at what's happening in all the countries, we have had the largest single day spike. Almost one single day cases are equivalent to all the cases reported in China. China, 86,000 cases, and one day we are reporting that. On the face of it, it looks a little alarming, but I'll explain why it's not alarming. A little later, we'll come to that. There's been a huge explosion of knowledge in this area in the last few months. Over 20,000 papers have been published. I think if you look at the progress of science that has happened in medical field, in no other specialty or no other single disease has so much been published in such a short time. All the leading medical journals are devoting a major part of their journal to this science of COVID. So therefore, huge knowledge has been obtained, and in our institute also the last 4 months, we have experienced with over 2,000 patients, so we obtained some of our knowledge. So what I'm going to, the basic thing that occurred is first, I think this time we discussed last time also, at that time it was not so clear, but now it's clear that the virus has undergone mutation, little mutation. The virus that is now present in India is called A2A, capital A, 2 and small a. It's called A2A haplotype. And one of the most important mutations that has occurred is at position 614 of the spike protein. We discussed this last time also that spike protein mutations are occurring. Now we know exactly what mutation. That is at position 614, aspartate is replaced by glycine, amino acid. Now this is, people believe it's an important mutation, but at present, there are two important things about this mutation. One is this mutation is not changing the immunogenicity of virus. In other words, because of this mutation, the vaccine effectiveness will be still there. People are worried virus is getting mutated, so will the efficacy of the vaccine change? No. This mutation is not changing the efficacy of virus. That is very good news for us. Now, whether this mutation is decreasing the infectivity or increasing the infectivity or decreasing mortality is still not known. Studies are going on, but overall, it looks like this mutation is not so dangerous. It's probably helping us a little in making the disease more mild. But still, studies have to be done in this area. So there's a definite mutation. Many mutations are occurring, but the most significant mutation is this D614G. D614G. I think this is important number. And again, the worry that the scientific world had is that this virus mutation, will it escape the vaccine because of this? That seems to be not so much now. We are not so much worried that even because of the mutation, it is still amenable to the antibodies generated by the vaccine. One of the things that we have done, I'll send you this paper also, that we have actually taken the structure of this virus and the structure of the entry, how it occurs very carefully. This is called receptor binding domain, RBD, which is present in the virus. Now, RBD, receptor binding domain, comes and sticks to the cells in the body, in the throat, in the lungs, and nose, and so on. And from there, the virus goes into the bloodstream. Now, we have now defined that RBD, receptor binding domain, very well, and we also defined which drugs will go and stick there to prevent this. And what we are surprised is that some simple things like, for example, bromhexine, which is cough syrup, which is present in all the cough syrup, can actually neutralize the virus at the receptor binding domain. Lot of work is going in this area now. Many people are trying to see what are the things that can block this receptor binding domain, and that knowledge now is very clear to us. And I'll send you that paper that we have actually published. So this is an important area. We understand the virus more very well. Still, the spike protein discussed last time also is still an important protein which is enabling the virus to attach to the body and come inside. And this spike protein, now we have developed antibodies against the spike protein. Vaccines are also developing antibodies against spike protein, and importance again I'll come to later. So this is again very important area, that basics of the virus we are now understanding. But one very important thing which is in news the last 3 to 4 days, I think you must have heard in the news, is regarding reinfection. Now, we have, the doctors have been telling that sometimes you're seeing patient cured, again getting some cases from China, some cases from South Korea report. But the most important evidence came from Hong Kong. In the airport, one patient had in April recovered completely, and then he came to Hong Kong from Europe, and then when they did the test again, he was asymptomatic, they found a virus of different genetic strain. Now, in this case, they could say 100% that this was a different virus strain, because they genotyped the virus first time and genotyped it second time, which is not commonly done. And because of that, this is the first documented reinfection. Now, day for yesterday, they have documented a reinfection in Nevada in USA also, the second documented reinfection. Now, but people are misunderstanding this. Again, we have to put it very clearly in perspective. This is not a disease. This is only reinfection. This is asymptomatic patients in whom the test was done and the virus was found. This virus, in this case, has not produced disease at all. It was just incidentally found. This is very important to remember, because the first time when this patient had the infection, he developed mild antibodies which decreased. After 3 months, they couldn't find antibodies, but only mild infection which completely resolved. So he developed immunity against this. And when he got the second time, the virus was present in the nose, but it went off. It didn't produce. He was put for 5 days in the hospital, then sent off. He developed no symptoms. It's only, so no disease. So we don't have to discourage by this. We don't have to worry about reinfection. This is a clear indication that even if the virus strain has changed, the body immunity was good enough to actually eliminate this virus without causing any problem. And it is hopeful that even the vaccine, same thing will happen. Even if the vaccine, even if you are in a crowded place, you get reinfected, the infection will be of no consequence to somebody who has antibodies. This is very clear. And also, it's very clear also from here that this is just not the antibodies. We used to think only antibodies are disappearing after 3 months, so protection may go up. But there is another immunological protection in the body from T cells. So antibodies are from B cells, but another immunological protection called the T lymphocytes, T cells. These T cells have a memory, and they are very long term. They may be there for 4 years, 5 years. Whenever infection occurs, these T cells are activated, they stimulate the B cells to produce these antibodies, and therefore protection is occurring. So this is the second thing that we have learned in recent times, that there is a T cell memory also. And some of the vaccines like the Oxford vaccine have clearly shown that in addition to the antibodies, the T cell memory also is being stimulated, and protection may be long term. 1 year may be definite, but even maybe long term, we'll only know in future what happens, whether every year we have to take the vaccine or maybe once in 5 years like some of the pneumococcal vaccine, so that we will know. Or influenza vaccine we take every year. So one good news about the virus is the mutation is not occurring like influenza vaccine. It is a little different. It is seems to be a mutation which is can be attacked by the antibodies. I think this is so. This reinfection concept has to be very clearly, the public has to understand that this reinfection is not recurrent disease, but virus has been found, eliminated by the body because already this is there. So this is important. The other thing that we are finding in recent years is saliva is becoming very important. Saliva is now becoming a diagnostic tool. Just yesterday evening, there was a big paper in New England Journal of Medicine which has shown that instead of doing blood tests, by testing the saliva, we can get the same results or better results. In our institution also, we have started this research study where we find that saliva is as good as blood test for detection of the virus. Now, why this is important? Very important is, now the present test you have somebody has to go take from the nose, take from the mouth patient. People have to wear PPE. People are frightened to go to houses to do this and all this inhibition. So therefore, our contact tracing, testing asymptomatic individuals is not being possible in large scale. We have the capacity to do large scale. Today, if you are doing 6 lakhs tests a day, we have the capacity to even double that amount. But because the limitation is healthcare workers and the swab, if now we know that if we have standardized it, that saliva is as good, then it becomes very easy. You can test the whole country also very easily, because then it's a question of just asking somebody to put his spit in a bottle and send it, and then immediately. So this is, I think, this is something which has not been brought to the attention for some reason from the public. I think this is going to be one major advance. Just yesterday only evening, New England Journal has published this paper, and our research also shows the same thing. The salivary testing may be as good, and this can become the major tool for the government in future. Just to ask somebody to send the spit, you can check up, and then the progress also can be monitored.
But is the testing method different in respect of saliva?
Saliva testing method presently is using the same RT-PCR. So the test will take 6 hours. But also some companies now in US, for example, and also we are working on that, have produced spot test with saliva. That is only half an hour test. But this is not validated. So I won't recommend immediately now. Still, there's some work going on. That may also come. Like pregnancy test, you put a small strip of urine, you know pregnancy or not. In saliva also, we'll get a test where you just spit on a slide and you'll know whether it's positive. But right now, what is validated and what is published very clearly is that saliva can be used for RT-PCR, and it becomes very easy. You can do tracing, contact tracing, huge population studies very easily. And saliva also now, we are looking at the antibodies. Even antibodies are appearing in the saliva very early. So even for surveillance, we can use saliva. You don't have to take a blood. So I think this is a major slow advance that is occurring without people noticing much, but that I think is important advance.
Going back to what you mentioned, Doctor, notwithstanding the highest number of cases per day, why do you think it is not allowed?
So that coming to that point about the number of, if you look at the number of infections in our country, in fact, even 77,000 is underestimation. My view is it will be at least 5 times more actually. The numbers will depend upon the number of testings. If you test 5 times more, you will get 5 times cases. Now, what is more important is not the number of cases, because in a crowded country like this, with people sometimes not using all the physical distancing, you are invariably going to get this like common cold virus spreading. You are invariably going to get this. But what is more important is the fatality rate. Now, if you look at the fatality rate, the case fatality rate in our country is lowest in the world. That is, now it is coming to 1.9 or 1.8 case fatality rate.
Yeah, little above 1.8, I guess.
Yeah, compared to say 3 point something in US or compared to 10% in Europe, it's coming to only 1.8. Now, not only case fatality, the actual mortality rate in terms of population is again more important. And that is very, very minuscule. If you take the total population, the mortality of corona is very less. In fact, compared to other countries, it's almost 1/20th. So very low. Now, people are saying, no, maybe they're not reporting all the mortalities. That's why the mortality rate are low. I don't agree, because mortality, especially with this virus, is in fact, people are oversensitive. Even people dying of cardiac problem or people dying of, say, malignancy, cancer, they do last test. Many people may have this virus as just carrying this virus, and it's reported as corona deaths. So in fact, I don't think underreporting is there in our country, because you can get statistics from March and all. So even if mild underreporting is, still mortality rates is very low. That's why I think we should not see this infection rates and worry so much infections are occurring. It's more important mortality rates that are more important. Now, infection rates increasing is good in the sense we have found again one more very important thing, that we have checked, for example, in our staff, all the staff was checked for the virus and for the antibodies. And we found that, say, some percentage of staff have developed this infection with the virus. You can make out anything. Or healthcare workers in a hospital. And when we looked at the antibodies, double the number of people are having antibodies. Which means silently they had exposure and they have antibodies. So which means if you have, say, 30 lakh people in India having this virus, I think it's an underestimation. It may be actually 1 crore people having this. Or another double or at least 5 times the number of people are actually having antibodies. So these antibodies are going to decrease the way the virus is spreading after a certain period. Now, will it happen end of September, end of October? We can't predict. But definitely as we go forward, September or October, the transmission will come down because of antibodies. In some areas, for example, in Delhi, for example, some serological studies by ICMR has shown 23% antibodies. 23% of the public has antibodies. You take Dharavi in Bombay, 50% have antibodies, and Dharavi transmission has come down almost complete. Very few transmissions come there. So this is going to come to us also. So even if the infection rates are high, provided mortality is not high, I think we don't have to this thing. Now, there are also other protective things. Again, there is some basic research we are doing. I can't reveal till it's published, showing why Indians are partly protected. But one of the things that has come now is this so-called immunological dark matter. There is some other immunological protective effect in our country, which may be related to past infections. BCG was counted, but not to be found. But we are exposed to so many coronavirus, and very important information. Again, last 1 week, there are many publications coming from Spain and other countries showing that people who have had exposure to past corona infection also seem to have some preventive antibodies which are helping against this corona also. So very strangely, they took samples from 2015 when this coronavirus was not there. The antibodies in those samples of blood in 2015 were showing protection against this virus, showing that there is some back protection also that's available. All these facts are now coming out. So therefore, I think we have now, we should be optimistic that we should not worry about it. I think the problem is people are equating the numbers to mortality in Europe and saying, okay, we have 77,000 things, so if 10% die every day, so many people will die. That is not happening. That is very important. That eventually, that's the reason why I told you.
I think people are less panicky now compared to what we have seen, say in April, May, and all that. And as one expert put it, do you think the cases are going up because the large section of population is basically indifferent to the pandemic?
Yeah, I think this is a very important point. We don't want them to be more panicky or less panicky. As you say rightly, if they're less panicky, what happens is that they will disregard some of this physical distancing and those things, and therefore and this is their evidence that I think you saw very clearly when markets are open, some people crowding, and when something is from functions, people are attending in large numbers without distancing. So this I want to again make it clear that although all this knowledge has come, that we are optimistic, but we still have to follow these regulations. Very important. Initially, people who are talking about hand washing, very important, very important. Now we know that hand washing is important, but less important than masks. So some extent, this knowledge of masks came to us only later on in May and all. Unfortunately, WHO also realized this late and put it out late. But what we realize now that these masks are important because the transmission is aerosol transmission. That is, this stays in the air for about 3 hours virus. So if in a closed room, if you stay in the same air, from person to person, it can transmit in the same air. So if 100 people are in the same room, aerosol transmission, this information now is very clear. And the aerosol transformation information has been now verified in several studies. But WHO was very slow in this. They came very late. So that's why masks, I think, are the most important thing. And there's one very important modeling that has been done. So there's one study which has been done that if masks are put on properly, if physical distancing, say 6 feet, they say, but sometimes if somebody is sneezing or somebody is coughing, maybe even 9 feet also, it can transmit. So if masks are put on properly, physical distancing is followed, then if universal, that is everybody in the society wears a mask and follows physical distancing, it is equivalent to 90% effect of lockdown. So if you completely lock down the country, economy goes, everything goes. The same effect can be got by just everybody wearing a mask and producing physical distancing. This has been shown now. So this aerosol transmission also has got a lot of importance, and now a lot of studies going on. Aerosol transmission is important in closed rooms. In closed rooms, it stays for 3 hours, whereas in outdoor, it is not as outdoor. If you maintain physical distance, wear a mask. Even if somebody is developing corona, you won't develop, because one is this air blows it away, so infection, and also it's inactivated by sunlight, radiation, all those things. So outdoor activities, outdoor people gathering in a larger number is still okay, but mask should be on. That's very important. But outdoor is much safer than. The other important thing is air conditioning systems. It has been shown that, for example, in flights, we are worried initially that flights will cause problem, but it has been shown that flights, because this air goes from the top to the bottom and is sucked out and new air comes in frequently. So if you have this sort of airflow, laminar airflow, if you have laminar airflow, then it is safe. Chances are less. That's why now hospitals are starting to adapt this. In many critical areas, we now have laminar airflow. So that even if it's indoor, because of laminar airflow, the same effect as outdoor is produced because of this. So that is also very important that we are starting to learn. That's why airports are more dangerous than airplanes.
Okay.
So this is because if you see now, I saw recently, I was traveling also to US and coming back. The aeroplane is very safe because like going off. But when you land in the airport, there were 2,000 to 3,000 people in the airport waiting for clearances and so on, because so much of customs, so much of other things are there. There are at a time 2,000 to 3,000 people in Delhi airport. There the chance is higher than in the airplane itself. So I think that's what we should realize now.
We now have a lot of repurposed drugs, which weren't there when we last spoke.
Yes.
So how useful they have been, doctor, in treating the patient?
Drugs, the issue has now become also very clear that we have understood the way this virus enters into our body, how it goes. Earlier, we used to think this virus goes into the nose, goes into the lungs, produces lung infection. This is not the right thing now. Now we know this virus has 2 phases. The first phase, it attaches itself to the nose, lungs, or even the intestines, and from there enters into the bloodstream of the body. This is called viremia. This viremia was not realized earlier. The first week, it produces fever, myalgia, body pains, and all that because of viremia. Not dangerous at that stage. When it goes to the second stage is the area where it is producing this cytokine responses. Because when body it enters into the virus, enters into the bloodstream, the body tries to react against it. The body tries to react against it by producing antibodies, by producing certain chemicals and so on. But still, if it is not cannot remove this virus, then it starts producing certain chemical weapons like chemical bombs. I call it the bomb because the first one is only infantry with guns. The second phase is the bombs which come with cytokines. These cytokines can damage not only the virus but the body. So all the problems with this virus is occurring in the second week because of damage, because of cytokines to the body. Rarely, occasionally, virus can attach to the heart cells, to the other cells, and produce like a heart attack or strokes, but that is not so common. Mainly, it is cytokine damage. So, all these antiviral drugs should be used in the first week. Only then they are effective. But unfortunately, even in Western countries, all these trials in America and all, the antiviral drugs were used in the second week. Therefore, they won't be effective. So these repurposed drugs. Now, of the repurposed drugs, we know that if you use them in the first week, especially remdesivir, is very useful. We have found that if somebody is above the age of 60 years, is having diabetes, hypertension, comorbid condition, or having very high fevers and all for 4 days and all. At this stage, in the first week, very early, we use remdesivir. And when we use remdesivir, we're finding that their illness gets remarkably controlled. Although, of course, it's a costly drug. Fortunately, Indian pharma is coming now and costs have come down. It's coming to 3,000 to 4,000 a vial now. For 5 days, we have to use it. So still it's worthwhile because this drug has definitely shown. This is our experience. And then recently, New England Journal also, the American experience has been published. When this drug was used early, they found that it decreased the viral load and this thing. So that's something that has been found useful. Now, other drugs, for example, Faprivi, that is Fabiflu and so on, still not much data is still there. There's still research going on, so we don't know. But remdesivir, definite.
From a layman's perspective, I mean, how do you explain this? I mean, a 70-year-old person is able to come out of it, an 80-year-old person is coming out of it, but a 50-year-old, a 45-year-old is succumbing to the virus. From what you said, is it will an early reaction from the patient? In the sense, the moment you find a symptom, you see a doctor and then take appropriate. Will that help, or what exactly?
So I think this is very important. Most of the deaths we are seeing are patients who are coming to us in the second week, after 10 days, 15 days, once the cytokine storm has come. Once the cytokine storm has come, we have very few things like steroids or very risky drugs like tocilizumab. Once the cytokine storm has come, our capacity to alter the disease comes less. So all these fatalities you are hearing are in people who are engaged also, who are coming little late. So that's the reason why we are suggesting that people who are symptomatic, asymptomatic, nothing happens, they're all getting. People who are symptomatic should within 3 to 4 days see the doctor. And then we can actually, so there's now we have developed a very compartmentalized, what I call a compartmentalized therapy. So first, we start immediately remdesivir. They respond, majority respond. In those who don't respond, we are now even giving very early plasma therapy. And this is an area where I'd like to, 2-3 points here important, because in last few days, plasma therapy has come into controversy, especially with the US President, FDA supporting it. In the presidential convocation also, he was supporting it. And then newspapers came out saying that FDA has given too early recognition, maybe it's wrong. Mayo Clinic studies, all controversies have come. Here also we are very clear. Plasma therapy has to be done very early, maybe within the first week. So timing of plasma very important. If you give it late, so all the studies, plasma is given and the patient is on a ventilator when he's dying, there's no point. Plasma therapy has to be given early, in my opinion, in the first week. Just as the cytokine storm is starting, we can give plasma therapy. Plasma therapy, just taking plasma from some patient who is recovered is not right. Convalescent plasma has to be before, that is, before we take plasma, we study the patient neutralizing antibodies, not even general antibodies. So when person gets infection, he develops several antibodies, IgM antibodies, IgG antibodies, general antibodies. But most important is neutralizing antibodies, which are against the spike protein. So nowadays, when we take plasma from a donor, we check neutralizing antibodies. If the neutralizing antibodies are more than 1 in 40, 140, these patients will have very good neutralizing effect. So if you take plasma, usually 3rd or 4th week after recovery, neutralizing antibodies are high, and give this plasma, definitely the patient will respond. We have seen dramatic responses in our patients when plasma is given early, especially when you check the neutralizing antibodies and give the plasma. So the timing of the plasma and the presence of neutralizing antibodies is important. People are not realizing, even Western countries is a problem. They're not realizing the importance of this. And that's why the thing is coming out, plasma controversy is coming. Regarding oxygen also, very important that we start oxygen, because these people, we ask them to check pulse oximeter in the second week. If the oxygen levels are going below 95, careful. Below 90, immediately come to the hospital. Because oxygen therapy we understood in this virus very carefully, because this virus, if you give adequate oxygen to the body, then when oxygen is occurring, again it's a question of if you can able to maintain the patient for a week like this, then it's good enough. We are unnecessarily doing ventilation very early, which is wrong, because ventilation causes barotrauma to the lungs and problem. Instead of that, what we are doing is now high flow nasal oxygen. There is a high flow nasal oxygen catheter that's available. You can give up to 40 liters per minute. So when patient comes to us initially, they may require 2 or 5 liters per minute. Very easy. Normal nursing homes, everybody can do. When they require higher oxygen, they're putting on ventilators. Now we have stopped that. Ventilators uses come down. Very, very important. Ventilators uses come down, and high flow nasal oxygen uses gone up. Using high flow nasal oxygen, we're able to save many more patients. So this is very important. And comorbid conditions also we're understanding better. Age is not a age, of course. If somebody is above 80 years, he can die, but the 60, 65 also is not so important. Age, more than age, of all the comorbid conditions, uncontrolled diabetes, one, and second important thing is obesity. We found this very important. People are dying are mostly those who are having obesity. Now, why this occurs? Again, recent research has shown that obese people have more fat cells in the lung, and this virus goes and sits in the fat cells. And once it sits in the fat cells, it stays for a long time and can produce this problem. So this is, I think, a very good occasion for all of us to realize that obesity is not good. Physical fitness is very important. And this can save many patients, physical fitness also. This is saving many patients.
One more question from my side. I mean, in this global rush to produce vaccine, there is a view that we are perhaps short-circuiting the normal checks and balances that doctors and scientists go through using a vaccine in the market. Do you feel we are doing the same?
So I think this is a very important point that we should not rush for a vaccine. The rush for a vaccine to some extent, unfortunately, has become politicalized. Each nation wants to say we are producing the vaccine and this type of thing is happening. Now, if you look at now world, what is happening, there are 231 vaccine candidates. 231, of which 25 vaccine candidates have been approved for clinical trial, of which 19 are in phase 1 and 2. And finally, 6 are in phase 3. This is the statistics. I think even if you look at what is happening now, we have fast forward a little in terms of how these vaccines are progressing. The 6 vaccines which are in phase 3 are from different countries, but I think they now realize the importance of these phase 3 studies. Of all these vaccines, only the Russian vaccine, which was in phase 1 and phase 2, has been sort of, the government of Russia has given permission to give it out to the public. Yeah. So there's a lot of controversy about that, and I think I agree that we should be going through phase 3. Why? The reason is, phase 3 only will tell us, although phase 1 and 2 is safety and efficacy is known, and we know that all the 6 vaccines are safe and efficacy is there. Phase 3 only will tell us about what will happen to the vaccine if given for large population, 30,000 people. What will happen? Large population with different types of, in different age groups, different comorbidities and all that. The reason why this is important is that with the dengue vaccine, we had a very bad experience. Dengue vaccine initially when it came, it produced protection. It also produced safety was there initially, phase 1, phase 2. But when it went into phase 3, we realized that it was producing what is called activation of the disease, dangerous activation of the disease. That is, those who took vaccine developed more dangerous disease because the antibodies which were there helped the virus to make the disease more dangerous. So this concept that the vaccine can also be dangerous came only after phase 3, and therefore this vaccine is now not available. So vaccine can have some long-term effects which are not known in the short term. So although all of us are desperate to have a vaccine, we should not have this vaccine till phase 3 is over for safety's sake, just for having the vaccine, because this phenomena can be there. One interesting thing in vaccine is so-called the challenge test, and this is some groups in America advocating. They're saying instead of going through all this phase 3 and all this, why not we take volunteers who are willing to come for this, give the vaccine and challenge these volunteers with the disease by the virus. This is very controversial because ethically it may not be right. Fortunately, none of the approving agencies have approved this, although there's a big push in America that this challenge test should be done and vaccine should be brought out immediately. But anyway, I think progress has occurred. But one of the other things about this vaccine is this is one of the first vaccine where 6 different platforms are being used for the vaccine. RNA platform, DNA platform, dead virus platform, adenovector platform, different platforms. And so this is one good thing and bad thing. The good thing is that Any one of the platform will definitely work because so many are being. Bad thing is some of the platforms we're trying for the first time, RNA platform and so on, and we don't know what is going to be the consequence long term. So that's why we have to be careful. But my belief is that in spite of all this, vaccine progress has been dramatic because maybe in beginning of next year we are going to get a definite vaccine from one of these 6 vaccines. Already the Chinese vaccine is being given to military people, Russian vaccine is being given to some countries are negotiating. So by beginning of next year, the phase 3 trials of at least all the 3 or 4 major vaccine will be over and we'll get the vaccines. Although availability we can't say. They have to be available over a long period of time. At least by middle of next year, a large segment of population there.
And what is your advice to the people of India now? I mean,
My advice is that we should.
Simple, basic steps that they need to take.
My advice is kindly don't panic, but at the same time, don't become too lenient. Don't think that everything is over, that we are safe. So a balanced approach is very important. We should not panic because although the infection is being reported in large numbers in the country, we have now conceptualized the correct modality of treatment. We have decreased the mortality rate, plus our mortality rate as such, even without all this, is very low. So therefore, what ultimately matters is the mortality rate, which is very low. Very effective treatment is coming, but don't be very lenient just because of that. Still, masks and physical distancing is very important. What I recommend is don't go for social distancing. Social distancing is mental distancing. We should not be there. Physical distancing should be there. Social distancing should not be there because we are finding that a lot of mental problems are coming. People under stress, anxiety. If you are very anxious, your immunity goes down. Your cardiac rhythm goes down. And this produces a lot of problems. Kindly don't have those. Be very optimistic and be very cheerful. Continue working from your home or even in your offices if there's proper distancing and all can be allowed. This is a course of another few months we are going to have this. We are going to overcome this. Effective vaccine will definitely come. We should be very optimistic. And I'm sure this is not going to be a small blip in the history of mankind that this occurred and we overcome it. And I think other important thing I keep saying to people is that don't look at the negative, look at the positive aspect of COVID. The positive aspects of COVID is that science is leap bounding. For the first time, thousands and thousands of papers are being produced on a single disease so rapidly. Major technological advances have occurred because of COVID. Like World War II, major technological advances occurred in blood therapy, plasma therapy. With COVID, major technological advances are occurring in forms of vaccines, immunotherapy, and so on. We are soon going to get monoclonal antibodies, which is a definitive form of treatment for COVID. So major advances are occurring because of this. Major advances are occurring in artificial intelligence and bioinformatics being applied to this disease, and they are going to become part of general medical advances. And I think this is again one area where biomedical engineering has taken major leaps and we are able to produce a lot of new devices and all these are going to be incorporated into medicine. And for youngsters now looking into future, I don't think they should look at MBAs or IIMs and all. They should now look at medicine because advances in medicine are occurring in such a high fashion. If they go into medicine and biomedical engineering at this point of time, they'll have a fantastic future because the whole field has suddenly opened up and gone into different directions. So I look at the positive aspects of COVID. It has definitely produced something very positive for scientific community.